Myself, Dr. Rohit Aggarwal. I am an endocrinologist based at Patiala. I am running my own hospital by the name of Aggarwal Healthcare and Eye Hospital. My wife, she's an ophthalmologist. We do all sort of diabetic testings along with the all hormonal testings and retinopathy checkup under one roof. Today, it's my pleasure to interact with you people, and I am going to discuss one case which comes to my OPD as a young diabetic, just to highlight how to tackle with young diabetic patient. You might be seeing a lot of diabetic patients, and my today point is we have to learn each patient is a different patient. So though there are many guidelines, whether you are talking about American guidelines, European guidelines, Indian guidelines, but we have to use our own judgment, our own sense to make the patient's condition better, and so that the patient live for a longer time without complications, whether microvascular or macrovascular complications. So let's start with a case. Mr. A, 58-year-old male with a non-history of diabetes for the last 4 years. He is obese, hypertensive, and hyperlipidemic. Also, he had a history of obstructive sleep apnea. So when we examined, the BMI was high, 32 kilogram per meter square, and we know that Asian guidelines, if anyone is having BMI more than 23 kilogram per meter square, we label them as a obese. The blood pressure was normal, that is 130/80, with a heart rate of 60 beats per minute. So what we have learned till time, we are dealing with a young patient. Even don't think that 58-year male is an old patient. It is a young patient with just a short history, just of 3 or 4 years history of diabetes. But the patient is obese, having other complications in the form of hyperlipidemia, in the form of obstructive sleep apnea, as well as hypertension. So we are not dealing only with the diabetes, so we are also dealing with the other comorbid conditions which this patient is having. Now we order the labs. And once the labs comes, to our surprise, his HbA1c, what we called as a glycosylated hemoglobin, it was high, that is 8.3%. Estimated GFR was 80 ml per minute per meter square, which is normal. Among the cholesterols, the LDL cholesterol was 70 milligram per deciliter, with the good cholesterol HDL was on the lower side, and high triglycerides. And to our surprise, when we order for the SGOT, SGPT, or what we call as AST, ALT, they are on the higher side, 70 to 100. By looking into this AST, ALT, we immediately ordered for the viral markers. Luckily, the viral markers were negative. So what we have gathered till young diabetic patient, obese diabetic patient, hypertensive, dyslipidemic with a good cholesterol on the lower side, obstructive sleep apnea history, and now the patient is also having non-alcoholic steatohepatitis in the form of raised transaminases, and viral markers were negative. So when we ask the patient, tell me what medicines the patient is taking, the patient was on metformin, that is the 1000 milligram twice a day, which is, I think, but obvious. Patient is taking lisinopril 40 milligram once in a day, metoprolol 100 milligram once a day, atorvastatin 40 milligram once a day, along with aspirin 81 milligram. So now if you go total profile, patient has a short history of diabetes, patient is young, though patient has no major comorbidities with no major complications that would reduce the lifespan. But if you see, the patient has got other associated problems in the form of hypertension, dyslipidemia, in the form of obstructive sleep apnea, non-alcoholic hepatitis. And if you combine all these things with obesity, it means the patient is having a metabolic syndrome, which is not good for the heart. And we know that all diabetic patients who have underlying this metabolic syndrome can have early cardiovascular diseases. So my point is here that we should focus more on cardiac part. We should focus more on the liver part, though the renal part is okay. But if you connect the dots, like the cardiorenal outcome will be bad in this patient if we don't intervene right here. That is number one. If you see now, when we start treating, so we should know what should be the goal. Goal means control of sugars, control of blood pressure, control of lipids, control of weight, which is most important, control of obstructive sleep apnea, and we have to do every effort to decrease the weight of the patient, because if you're able to decrease the weight, then I think most of these comorbidities, they will come down. So if you see the ADA goal, so our aim is to keep your HbA1c less than 7, since the patient is young. Patient does not want to have multiple medicines also. Our aim is to keep close to 6.5 in a younger age group without risking the patient to go for hypoglycemia. So meaning by that, we have to choose that drug which not only controls the sugar, which also helps in controlling weight, helps in reduction of weight, along with that, no risk of hypoglycemia. That is our main aim. Now, but here what we have advised the patient, now you go for the GLP-1 receptor analogs, which are there in the market in the form of liraglutide, where we have to give the 1 daily injection, or once in a week, this thing dulaglutide, available by the name of Trulicity or Aplivant. But here the patient says, I don't want to have any injections, whether you're talking about the GLP-1, you talk about the insulins. Dr. Saab, in case if you have something to offer me, give medicines. I will love to take the medicines, but I won't take the injection. He has its own myths about the injectable therapies. Even we tried my best to explain that GLP-1 receptor analogs are the best for you, but the patient said, no injections. So now, and the second, say the question or the patient thirst on, whatever the medicine you give to me, please, it should be a minimum. Don't give the plethora of medicines, because it is very difficult to take so many medicines morning, evening, and night. I don't want to make my life hell. Okay, my sugars are bad, but treat with a minimum dose, with a smaller medicines, so that I will remain happy. Now, so people with type 2 diabetes commonly live with, we know that, multiple comorbidities, among with hypertension and cardiovascular disease is the most common. So monotherapy, single medicine, cannot address these multiple defects, and it often leads to failure to maintain glycemic control over the time. So the current guidelines encourage early adoption of combined therapies while simultaneously emphasizing the importance of individualized treatment. So when we say individualized treatment, so every diabetic patient is a different patient. In this patient, we have to individualize our therapy, because patient does not want GLP-1 receptor analogs, patient does not want insulin, his HbA1c is bad. We know that there is a whole life, half of the life it is there in front of the patient, and we don't want the patient to suffer from cardiovascular, renal, or the hepatic issues. So we have to choose that drug which is not only controls the sugars, but also controls the weight and helps in lowering the weight, plus does not allow the patient to become hypoglycemic. In this subset of the patient, from my point of view, the combination of empagliflozin and linagliptin, that is SGLT2 and DPP4, will be the drug of the choice. We know that SGLT2 inhibitor, it is a very novel oral glucose lowering agent, which helps in glucose lowering action by increasing the urinary glucose excretion and via inhibition of sodium glucose co-transfer 2 receptor in the proximal tubules of the kidney. The salutary effect is its ability to act independent of insulin secretion, number one, and action, and rendered it suitable to administer at any stage of the course of the disease. And the combination with the DPP4, it exerts its glucose lowering effect by elevating the incretin hormones which are being secreted from the small intestine, and these incretin hormones helps in secretion of the insulin, plus they decrease the secretion of the glucagon and helps in lowering the sugar levels. So if you combine these two drugs, so they have got a not only you say the supplementary actions, but the actions are complementary to one another also. What we say, diabetes is disease which is caused by ominous octet. What do you mean by ominous octet? Ominous octet is there is a defect at the 8 pathophysiological sites, whether they are right from the brain to kidney, to small intestine, to pancreas, to the muscles, to liver, to the kidneys. Now, so if you combine SGLT2 plus DPP4 along with the metformin, which we are supposed to give in all diabetic patients until and unless it is contraindicated, then they cover 7 out of 8 pathophysiological sites. So meaning by that, combination of SGLT2 with DPP4 along with the metformin, it is the ideal choice in all type 2 diabetic patient until and unless there is strong contraindication. And if you recall the famous EMPA-REG outcome trial, they reported that the 3-point MACE outcome occurred in significantly lower percentage of patients in who were put on SGLT2 as compared to placebo on top of standard care. So in addition, cardiovascular safety data of linagliptin was further elucidated in other trials like Carmelina and Carolina. So once we started, put the patient on this combination along with the metformin, and the baseline A1c, which was 8.3, after 3 months of the therapy in this patient, the HbA1c came down to 6.7. So there was no single episode of hypoglycemia. Patient lost 6 kg of the weight over a period of 12 weeks, which is a very handsome. BMI came down to 27, what we want close to 23. And the most important, the blood pressure start coming down. The patient lisinopril, which was on 40 milligram, or dose was 20 milligram. The HDL cholesterol went high, the triglycerides came down, and most important part, the effect on the liver, that is the raised transaminases levels, came back to the normal, that is 35 and 38 in this patient. So the take-home message from the today's case is, please treat all diabetic patient as a challenging patient. Don't say, okay, you are a diabetic, start with this drug. So look for the comorbidities, look for the cardiovascular status, always screen for retinopathy, for your nephropathy, neuropathy, plus I want to say for the hepatopathy also, because what we have seen, most of the patients, they are dying of non-alcoholic steatohepatitis in our area. So we have to rule out alcohol use. We have to go for the viral markers. So now choose that one drug which takes care of not only glucose, but takes care of heart, takes care of kidney, takes care of liver also. And if a choice is given, the combination of empagliflozin plus linagliptin, or what we call the SGLT2 inhibitors plus DPP4 inhibitors, they are not controlling only sugars, but they control our vital organs also. If we are able to control our vital organs, so the lifespan of the patient will be, much more increase, and the patient can live happily without having any complications in their life. To summarize, this combination of EMPA and Lina provides a robust HbA1c reduction and 2 to 4 times higher odds of patient reaching the goal A1c as compared to the individual agents with a very, very low risk of hypoglycemia. So thank you all my listeners for the patience hearing. And in case if you find any problem in managing the diabetic patients, you can call me. My number is 95695 29520. Thank you once again.